A very good morning. We are all set to start our Neuropathology Module 2, which is Hypoxia and Stroke. And this is the part 1 of the 2 lecture series that will be discussed. So what do we plan to discuss? We plan to discuss Hypoxic ischemic encephalopathy, its pathogenesis and microscopy, Gliosis and how is it different from glioma, types of stroke, that is ischemic, hemorrhagic and transient ischemic attack, etiology of stroke or cerebrovascular accident, pathogenesis and microscopy of ischemic and hemorrhagic stroke, a special mention about COVID-19 or SARS-CoV-2 associated ischemic stroke, and the key takeaways. So without much ado, let's start. The brain is about 2% of the total body mass, but however consumes 15% of the energy generated in the body, more than any other organ, including the muscles. The bulk of this ATP is derived from the oxidative phosphorylation of glucose, which is the main source of energy for the brain. This glucose is transported via the blood-brain barrier, which is composed of the astrocytic end feet and the cerebral capillaries, typically the tight junctions. The most common cause of energy crisis is a drop of the cerebral perfusion, that is, global ischemia. In generalized seizures, neurons use up glucose and oxygen much faster. So just a recapitulation of the blood-brain barrier. So let me just show you with the help of a laser pointer. So this is the astrocytic end feet that we were talking about, and this is the tight junction. The tight junction at the level of the endothelial cells and this astrocytic end feet together produces the blood-brain barrier, which is responsible for the transport of the glucose from the blood to the brain parenchyma. So what is hypoxic ischemic encephalopathy? As the term implies, it is hypoxia with ischemia resulting in brain damage or encephalopathy. But how does this happen? There is failure of sodium and potassium pump, which causes depolarization and release of excitatory glutamates. This glutamate is discharged at the synaptic cleft and that opens the NMDA and AMPA receptors, resulting in calcium influx. The calcium influx is responsible for the activation of the catabolic enzymes and activation of nitric oxide synthase and nitric oxide production, generating free radicals. Activation of the catabolic enzymes causes destruction of the membrane lipids and nucleic acids, subsequently resulting in neuronal necrosis or cell injury. This basically happens because of the effect of the glutamate excitotoxicity, and that is the one which results in hypoxic ischemic encephalopathy. Now, severe global hypoxic ischemic injury in adults most often involves the cortex, fairly diffusely the deep gray matter. But why the gray matter? This is because the gray matter has a high metabolic requirement for oxygen and glucose to supply a large number of synapses. Severe hypoxic ischemic injury is accompanied by cerebral edema. The edema at first is cytotoxic and subsequently becomes interstitial. Overactivation of channels result in influx of chloride and sodium into the cell, and that results in osmotic or cytotoxic edema and cell death. This is subsequently followed by vascular injury and release in the interstitial spaces of vasoactive metabolites like arachidonic acid, which is responsible for interstitial cerebral edema. So what is the etiology of hypoxic ischemic encephalopathy? Now, depending on the age, in neonates, neonatal hypoxic ischemic encephalopathy is associated with basically neonatal asphyxia. Whereas in older children, it may be associated with drowning and asphyxiation. In adults, however, it is associated with cardiac arrest or cerebrovascular diseases. The term hypoxic ischemic encephalopathy encompasses causes of hypoxia, ischemia, hypoglycemia, and effects of prolonged seizures. Shock and cardiac arrest develop at some point in most cases of hypoxic ischemic encephalopathy. So what is the pathology of hypoxic ischemic encephalopathy? If we sum it down, there is energy failure, as we have already discussed, sodium and calcium overload, and nitric oxide production, which subsequently results in neuronal injury or cell injury for that matter. The immediate effects include necrosis and cell death, whereas the delayed effects include mitochondrial dysfunction, caspase activation, apoptosis, and cell death. Any intervention, that is medical intervention if I'm talking about, needs to be started within 6 hours of insult. However, it must be noted that ischemia lasting for 4 to 5 minutes can irreversibly damage the hippocampal and neocortical pyramidal neurons, striatal neurons, and Purkinje cells. This typically happens because these structures are, yes, they are very vulnerable. There is a selective vulnerability of the hippocampal and neocortical pyramidal cells, striatal neurons, and Purkinje cells. This selective vulnerability will be discussed in just a bit. So now coming to the histopathological features. At first, the injured neurons shrink and become eosinophilic. This is due to increased density of the damaged mitochondria. Neuronal nuclei condense, and the shrunken eosinophilic neuron is also called as anoxic neuron, or the red neuron, is the characteristic hallmark of hypoxic ischemic encephalopathy. So here you go. Let me just highlight it with a laser pointer for you. Yes, so here you go. You have this anoxic neuron, okay, which shows a characteristic eosinophilic cytoplasm and a quite condensed nucleus. Okay, there is also a perineuronal edema that can also be appreciated here. So now, besides the anoxic neurons, swollen astrocytes or type 2 Alzheimer's cells are also noted in hypoxic ischemic encephalopathy. However, note that this has nothing to do with Alzheimer's disease, because it was Sir Alzheimer who first noted these swollen astrocytes, and hence the term. So how do these swollen astrocytes look? As we had discussed in the previous class of hepatic encephalopathy, where these swollen astrocytes typically have a clear nucleus because of the margination of the nuclear chromatin, and they have a inconspicuous basophilic nucleoli, as you can very well see. Now, how does this happen? It's been noted that the presynaptic neurons typically release glutamate, okay, which is the excitatory neurotransmitter. However, not all the glutamate binds to the postsynaptic neuron. Rather, only 20% binds to the postsynaptic neuron. What about the 80% then? It is this 80% glutamate which binds to the glutamate receptors which are typically present in the astrocytes. The astrocytes, you must note, are involved in uptaking this glutamate and recycling it back to the neuron in the form of glutamine. This reaction is completely catalyzed by glutamate synthetase. However, there is also another mechanism by which glutamate produces ATP through the TCA cycle. It must be noted, however, that in ischemia there is a failure of uptake of glutamate, and in addition there is also excessive release of this glutamate, which results in glutamate excitotoxicity noted in hypoxic ischemic encephalopathy. And therefore, this worsens hypoxic ischemic encephalopathy. Now, if a patient survives longer, then what happens is that the damaged neurons are removed by a phenomenon called as neuronophagia. So here you have a damaged neurons, and they are all surrounded by the microglia or the macrophages for that matter, and this phenomenon is called as neuronophagia. With time, that is about 2 to 3 weeks later after injury, cortical atrophy and or gliosis develops. Okay, so what is cortical atrophy? Where you have widening of the cortical sulci here, enlargement of the ventricles when you compare it from the normal side. Okay, and in addition you have thinning of the cortex if you compare it with the normal side here, and there is also shrinkage of the hippocampus. Gliosis is what is shown alongside. Now what is so now coming to gliosis. Gliosis, also called as astrocytic gliosis or astrogliosis, is a common term that refers to reactive astrocytic response, not only to brain injury but also to infections, infarctions, demyelinating disorders, and neoplasms. In gliosis, astrocytes hypertrophy, the nuclei often enlarge and the chromatin becomes dispersed and less dense, and the nucleoli often becomes prominent. There is increase in the number of organelles and a higher production of the intermediate filaments, typically the GFAP, nestin, and vimentin. And this results in greater and highly condensed glial processes and fibers. The increased glial processes often replace the injured CNS cells and form a characteristic gliotic scar. With gliosis, there is release of cytokines and growth factors and also extracellular proteins which may be involved in immune response, neuroprotection, or for that matter, possible further damage. Fibrillary and especially the gemistocytic gliosis may at times be difficult to distinguish from a low-grade infiltrating astrocytomas, which are often associated with gemistocytes. No mitotic figures or calcification, however, are noted in case of gliosis. So if we sum it down, the astrocytes may acquire nuclear enlargement and appear atypical, but the abundant cytoplasm, richness of the cell processes, and their even distribution reveal their reactive nature. So now how do we differentiate gliosis from glioma? So coming to it one by one, we have the cellularity. The cellularity may be high in both the cases. Okay, that is both in gliosis and glioma, but the nuclear chromatin is very important. In gliosis, the nuclei are euchromatic and may be round to ovoid, whereas in a glioma, the nuclei are more so hyperchromatic and the nuclei appears to be irregular when taking into consideration astrocytoma, or it may be round or fried egg somewhat in case of oligodendroglioma. Astrocytes are evenly spaced in gliosis and they have thin, note, they have thin radiating glial processes. On the other hand, astrocytic cells of astrocytoma often cluster and they have shorter and thicker glial processes. Mitosis, necrosis, and calcification is typically absent in gliosis, whereas it may be present in a glioma. Subpile and or subperineuronal satellitosis, which is also called as the secondary structure of Scherer, are usually absent in gliosis, whereas it is a mode or a pattern of spread which is typically seen in gliomas. Gliosis usually has a lower proliferation index when taking into account the Ki67 labeling index, whereas a high Ki67 labeling index has been noted in gliomas. P53 is comparatively negative in gliosis when comparing it with gliomas, which typically shows a strong and diffuse P53 staining. When taking into account the radiology, we find that gliosis often contracts, whereas gliomas expand. So this is a microscopic picture of gliosis versus a diffuse astrocytoma. And what you see here, you have thin, fine astrocytic processes that you note here, whereas the astrocytic processes are comparatively thicker and shorter in a diffuse glioma. And besides that, the nuclear chromatin is quite hyperchromatic in a diffuse astrocytoma when comparing it with a gliosis, where the chromatin is typically finely dispersed. Now, what are the secondary structures of Scherer? Perineuronal satelitosis. So this is a neuron here and these are the cells. Okay. There is a perineuronal satelitosis. There may be a perivascular satelitosis as seen here. Okay. In addition, there may be a subpile spread. Okay. And what is not shown here, there may be invasion along the white matter tracts as well. What are primary structures of Scherer? They are nothing but the morphological patterns due to the intrinsic tumor biology which manifest independently of a pre-existing tissue. For example, rosettes, pseudo-rosettes, whorls, papillary structures, as well as canalicular and glandular formations. So who was Scherer? Sir Hans Joachim Scherer was an under-recognized pioneer who studied the tumor biology of gliomas, okay, in the early 1930s. So this is Sir Scherer, and he was the pioneer who studied the malignant behavior, or rather the tumor biology of gliomas way back in 1930s. Now, in neonates and fetus with hypoxic ischemic encephalopathy, the condensed neuronal nuclei often fragment. Okay, so this is there what you see nuclear fragmentation, yeah, and this results in what is called as karyorrhexis. So karyorrhexis is one of the very common features which you appreciate in neonatal hypoxic ischemic encephalopathy. Some cases of hypoxic ischemic encephalopathy, usually after a brief period of insult, often undergo neuronal death. And this neuronal death is quite selective over the glial death because the neurons are more sensitive as they have a high energy requirement and they are the ones that produce glutamates, right? So this is referred to as a selective neuronal necrosis. On the other hand, some neurons are more vulnerable. As we have already discussed, the pyramidal neurons, okay, or rather the hippocampal pyramidal cells, the pyramidal neocortical neurons, the Purkinje cells, the striatal neurons, and they are the ones which undergo irreversible injury, especially within 4 to 5 minutes of ischemia. So this phenomenon is referred to as the selective vulnerability of these neurons. The cerebral cortex and striatum are more sensitive than the thalamus, and the thalamus in turn is more sensitive than the brainstem to hypoxic ischemic encephalopathy. The spinal cord may remain uninjured even when the rest of the CNS is severely damaged. The most likely explanation of the selective vulnerability is that there are susceptible neurons which produce more glutamate in the cerebral cortex and striatum when comparing it with the thalamus and subsequently with the brainstem. In severe cases of hypoxic ischemic encephalopathy, neurons as well as the glial cells undergo a damage. Rarely, the hypoxic ischemic encephalopathy involves the white matter causing myelin damage and loss. This results in vacuolization and a spongy appearance of the white matter in tissue sections, and this white matter damage is typically noted in carbon monoxide poisoning. So the key factor that converts the selective neuronal necrosis to total tissue necrosis is probably lactic acidosis. So this is what we need to remember. Now coming to the types of strokes. There are basically 3 types of stroke. Okay, one is the ischemic stroke, which results from an obstruction within the vessel, okay, supplying a particular part of the brain. The other one is the hemorrhagic stroke, where there is weakened vessel wall which often ruptures, for example, an aneurysmal rupture resulting in a hemorrhagic stroke. Or for that matter, there may be a transient ischemic attack. What is that? This is caused by a temporary clot which often blocks the vessel, and this results in what is called as a mini stroke. Now coming to ischemic cerebrovascular accident or the ischemic stroke, this group includes the transient cerebral ischemia or the transient ischemic attack for that matter, cerebral infarction due to thrombosis, cerebral infarction due to any embolism and or lacunar disease. Hemorrhagic stroke is a group which typically includes intracerebral or parenchymal hemorrhage and a spontaneous subarachnoid hemorrhage. So let's discuss this one by one. Coming to cerebral infarction, now this is a focal brain necrosis due to complete or prolonged ischemia that affects all tissue elements, neurons, glia and vessels. Ischemic infarcts cause focal neurological deficits. Atherothrombotic infarcts are often preceded by what is called as a transient ischemic attack. Now what is a TIA? A TIA or a transient ischemic attack is a focal neurological deficit that lasts less than 24 hours and then resolves. It basically happens due to, just let me highlight it with a pointer. So this is the vessel which is shown here and this is the blood clot that develops. Okay, but however, this blood clot falls short of causing a permanent tissue damage, or for that matter, this blood clot that produces an emboli, this emboli breaks up soon, okay, so that the vessel is no longer obliterated and becomes patent. Now what is an ischemic penumbra? The basic mechanism of cell and tissue injury that we discussed in hypoxic ischemic encephalopathy may also apply to infarcts. The release of osmotically active substances like the arachidonic acid, electrolytes and lactic acid may be responsible for what is called as cerebral edema. This is aggravated by vascular injury and leakage of the proteins into the interstitial space, resulting in what is called as interstitial edema. So by 3 to 4 days, interstitial fluid accumulates in the infarct and also around it. So in the early infarct, what you see is that this is the zone that develops. Now this, what is the zone? This is the ischemic zone. This central core of total ischemia and necrosis is an irreversible area of damage. On the other hand, the zone which surrounds it is a borderline ischemic zone and is called as the penumbra or the ischemic penumbra. Okay, why is it so important? This is because prompt restoration of perfusion in the penumbra by injection of thrombolytic agents may prevent structural damage in this area, thus limiting the neurological deficit. If adequate blood supply is not restored within 3 hours, then what happens? Necrosis may extend into the penumbra. Now coming to the microscopic examination of a cerebral infarct. Within first 24 to 48 hours, you will see what is called as anoxic neurons, and these are the anoxic neurons or the red neurons, which typically has a condensed cytoplasm due to condensation of the mitochondria and a very small pycnotic nucleus due to condensation of the nuclear chromatin. Here on the other hand, these are all the Purkinje cells that you see. Okay, and what do you see? There is also anoxia that is appreciated in the Purkinje cells, and they have now become the red neurons. During the first week, okay, there is a transient inflammatory response that you note. You have a lot of neutrophilic infiltration around the blood vessels and also around the neurons that happens due to the typical release of arachidonic acid and other fatty acids. So as the core of the infarct disintegrates, endothelial cells from the periphery start proliferating and capillaries start growing into the dead tissue. Neovascularization peaks at around 2 weeks. And this neovascularization is the one which is responsible for the contrast enhancement noted on a CT scan. So these are the vessels and they are the ones which start proliferating and growing into the dead tissue. Monocytes from the bloodstream enter the infarct through the damaged vessels. They ingest the product of degradation of neurons and clear the liquefactive necrosis. They also clear the degenerated myelin and are transformed into lipid-laden macrophages. This response is quite early, however, it peaks at around 3 to 4 weeks. The foamy macrophages, as shown here, are the ones which are responsible for cleaning up the lipid debris from the liquefactive necrosis. After cleaning the area of the liquefactive necrosis, what develops subsequently is a clear space, and that is what is referred to as the cystic space. This cystic space, therefore, results after the resolution of the liquefactive necrosis by the influx of the blood monocytes, which later on change into tissue macrophages. Astrocytes from the surrounding undamaged brain start proliferating and form what is called as the glial scar. This is completed by approximately 2 months. After that, the infarct remains unchanged. With the maturation of new capillaries and formation of what is called as the glial scar, the blood-brain barrier is now sealed. Now, the neurons which have been degenerated and injured cannot regenerate. So, there is always some part of the brain tissue which is lost forever. Okay, so now what are lacunar infarcts? Lacunar infarcts are small infarcts in the deeper part of the brain that is typically involving the basal ganglia, thalamus and the white matter, as well as the brain stem may also be affected. They are responsible for about 20% of all the strokes. They typically occur in individuals who are hypertensive or diabetic and characteristically involve the deep penetrating branches of the major cerebral arteries. They are often associated with severe atherosclerosis of the small vessels and small vessel disease. So now what are the causes of this ischemic infarction? As we all know, there is atherosclerosis or atherothrombosis for that matter, small vessel disease, cardioembolism, vasculitis, arterial dissection, polycythemia, thrombocythemias, thrombotic thrombocytopenic purpuras, sickle cell disease, SLE, vascular spasm, meningitis and fungal vasculitis, disorders associated with hypercoagulability like factor V Leiden and APLA, that is antiphospholipid antibody syndrome, inherited metabolic disorders like Fabry's disease, homocystinurias, fibromuscular dysplasias, and there are several other genetic angiopathies as well. So let's discuss. Now, what is atherosclerosis or atherothrombosis? Briefly, atheromatous plaques start to form, okay, or rather begin as an intimal thickening with the accumulation of blood-derived lipids in the intima. There is subsequent disruption of the interna elastica and there is accumulation of lipid-laden macrophages. Subsequently, there is formation of cholesterol crystals and deposition of calcium. So, atherosclerosis typically involves the circle of Willis and the large leptomeningeal arteries and extends into the smaller branches as well. So, this is the picture of a normal artery, human artery, okay, with an intact endothelium. Whereas this is a picture which shows you a damaged endothelium and the smooth muscle cell proliferation in the tunica media with infiltration of the macrophages which have transformed to the foam cells here. And there is subsequent laying down of lipids and calcium together with sealing of this entire thing by a fibrous cap. So this entire thing results in the formation of an atherosclerotic plaque which allows in the narrowing of the arterial lumen. Now coming to a small vessel disease. Small vessel diseases include atherosclerosis of small arteries, but refers more specifically to arteriosclerosis. So how do you differentiate these two entities? Arteriosclerosis has been typically associated with hypertension and diabetes. Okay, the affected vessels, as you can see, have become thickened Okay, and there is deposition of this hyaline material, this glassy material along the vessel wall, which is typically nothing but the collagen and also the plasma proteins. The pathogenesis may vary when you're considering hypertension. It is caused by endothelial injury and leakage of the plasma proteins in and around the vessel, whereas in diabetes, it probably has to do with the glycation of proteins and there is a diffuse basement membrane thickening. Now, what is embolism? Embolism is one of the most frequent causes of ischemic infarction, right? That is what it is. Now, most emboli are fragments of blood clots that originate in the heart or major vessels. Conditions that are associated with formation of emboli include the myocardial infarction, the atrial fibrillation, and other causes of arrhythmias, rheumatic heart disease, bacterial and non-bacterial endocarditis, prosthetic valves, mitral valve prolapse, atrial myxomas, calcified mitral annulus, and cardiomyopathies. Now, some emboli consist of atheromatous material which is often detached from the ulcerated atheromas of the aorta or for that matter carotid arteries. Okay, vascular manipulations like angiography may also cause an atheromatous embolism. Rare causes of embolism include fat, air, and also tumor emboli. So what is this fat embolism syndrome? Discussing it briefly, it is nothing but a complication of the long bone fracture, orthopedic surgery, and traumatic lesions of the viscera and or subcutaneous tissue, including burns. So all of which can result in formation of emboli and subsequent ischemic stroke. Now, what is vasculitis? CNS vasculitis now can be classified into the following categories. One is the systemic vasculitis with CNS involvement that typically happens in giant cell arteritis, polyarteritis nodosa, Wegener's granulomatosis, Takayasu's arteritis, and Kawasaki disease. The most common cause is, yes, as we know, it is the giant cell or the temporal arteritis, which typically affects the elderly individuals and women and is often associated with polymyalgia rheumatica. What is this giant cell arteritis? There is typical involvement of the temporal artery and therefore temporal artery biopsy is diagnostic. Giant cell arteritis can affect aorta and other extracranial vessels as well. Involvement of the ophthalmic artery usually results in visual loss. Giant cell arteritis has been associated with the T-cell mediated autoimmune disorders. Okay, and it must be noted that there is typical infiltration of the lymphocytes and the multinucleated giant cells in the vessel wall that characteristically disrupts the internal elastic lamina and subsequently narrows down the vascular lumina and results in thrombosis. So there are some secondary causes of vasculitis like the infections, bacterial, viral or fungal, collagen vascular diseases like SLE and rheumatoid arthritis, and drug-induced vasculitis. Fungal vasculitis is most frequently caused by aspergillus and mucormycosis. Okay. So what is this? This is nothing but the fungi which are branching at acute angles, as you can very well see, and this is nothing but an aspergillus associated vasculitis. Primary angiitis of the CNS. The criteria includes the presence of neurological or psychiatric deficits, angiographic or pathological documentation of vasculitis, and absence of any evidence of systemic or secondary vasculitis. Pathologically, primary angiitis of the CNS can be subdivided into the granulomatous and the non-granulomatous varieties. The granulomatous varieties typically affects the small and medium-sized leptomeningeal and cortical vessels and causes headache, seizures, focal deficits, and encephalopathy. Affected vessels may have amyloid deposits in addition to epithelioid cell granulomas and giant cells. However, there are no vasculitis outside the CNS. The non-granulomatous one, on the other hand, only shows lymphocytic infiltration. Okay, so this is a case of a granulomatous Pachynes. That is a primary angiitis of the CNS. So now what are the other causes of arterial occlusion and infarction? They include hematological disorders like we've already discussed, sickle cell anemia, polycythemias, anticoagulant factor deficiencies, thrombotic thrombocytopenic purpures, metabolic disorders like Fabry's disease, homocystinurias, dyslipoproteinemias, traumatic disorders, specifically trauma to head and neck regions and dissecting aneurysms. Contraceptive usage and estrogen therapy has also been associated with venous thrombosis and rarely intimal hyperplasia and thrombosis of the cerebral and extracerebral arteries as well. Now coming to genetic angiopathies, cerebral autosomal dominant arteriopathy with subcortical infarcts and ischemic leukoencephalopathy. Yes, it's a big terminology, abbreviated to CADASIL, is caused by mutation of the Notch3 gene, and this is typically associated with a small vessel arteriopathy in which there is deposition of a granular eosinophilic material in the vessel wall, which causes loss of smooth muscles, thickening of the wall and narrowing of the lumen. Okay. So there is another autosomal dominant angiopathy due to mutation of the COL4A1, which encodes the collagen of the vascular adventitia and causes porencephaly in infants and a spectrum of diseases in adults as well, which includes small vessel diseases, lacunar infarcts, microhemorrhages, deep cerebral hemorrhages, intracranial aneurysms, and leukoencephalopathy. On the other hand, there is a condition called as cerebral amyloid angiopathy, which is associated with deposition of the A-beta amyloid in the vessel wall, and this is the immunohistochemistry of A-beta amyloid, which highlights this amyloid in the vessel wall. So we have this A-beta IHC available now, and this is how we can highlight the amyloid in the vessel wall. Now, SARS-CoV-2 associated ischemic stroke. COVID-19, yes, it was a horror for all of us, right? So COVID-19 is associated with multiple neurological manifestations and includes anosmia, headache, impaired consciousness, delirium, ischemic stroke, and there are several others. Autopsies in few patients with COVID-19 have revealed microthrombi and hypoxic ischemic pathologies such as the cerebral infarcts, hypoxic lesions, hemorrhagic and non-hemorrhagic white matter lesions, and other changes typically associated with cardiorespiratory events. Perivascular lymphocytic infiltrates have also been noted in the brain stem. So if we see the pathogenesis behind it, we find that it is, let me just highlight it with a laser pointer for you. Okay, so it is nothing but the SARS-CoV-2, okay, which allows increased proliferation or stimulation of monocytes. These monocytes typically produce a lot of cytokines here and generate what is called as the cytokine storm. This cytokine storm subsequently induces production of tissue factors, okay, and also activates the endothelial cells and platelets. Endothelial cell activation results in the release of von Willebrand factor, which typically activates the platelets and induces platelet aggregation and coagulation through the tissue factor and factor 7. And it also inhibits the endogenous fibrinolysis. Increased activation via the cytokines of the neutrophils results in neutrophilia, and there is also activation of the neutrophilic extracellular traps or the NET. This NET amplifies the thrombus formation, resulting in both arterial as well as venous thrombosis. So this is how SARS-CoV or COVID-19 causes ischemic stroke by production of thrombosis with the help of the cytokine storm induced by the monocytes, activation of the endothelium and the tissue factor activation, resulting in the formation of a blood clot, which is subsequently enhanced by neutrophilic extracellular trap formation and resulting in the formation of a characteristic thrombus. This thrombus subsequently lodges inside the brain and results in an ischemic stroke. Now coming to the several causes of subarachnoid hemorrhage. Now why are we discussing subarachnoid hemorrhage? This is because, as we have discussed, subarachnoid hemorrhage is one of the major causes of hemorrhagic stroke. And what causes subarachnoid hemorrhage? There may be vascular inflammation like seen in cerebral amyloid angiopathies, vasculitis, cerebral vasoconstriction syndrome, postpartum cerebral angiopathy, vascular malformations which may be pial or dural arteriovenous fistulas, cavernomas, mycotic aneurysms, brain tumors, primary or metastatic, abscesses. There may be a dissecting aneurysm that ruptures, resulting in a subarachnoid hemorrhage, okay, and coagulation disorders due to anticoagulation and thrombocytopenias. So we come to the gross and microscopic features of subarachnoid hemorrhage. Okay, so this is a subarachnoid hemorrhage which has resulted from the characteristic rupture of the saccular or Berry's aneurysm, which has resulted from the outpouching of the vessel wall. The microscopy shows presence of blood and fibrin in the subarachnoid space, as we can appreciate. What about the cerebral cortex? The cerebral cortex shows features of ischemia, that is, there is perineuronal and perivascular edema that you can very well appreciate here. And what are these then? These are nothing but the red neurons. The background shows features of gliosis. So, what are the key takeaways? The key takeaways being global hypoxic ischemic injury in adults most often involves the cortex and mainly, yes, the grey matter. Cytotoxic edema develops in the initial phases of the disease, and this is followed by interstitial edema. The term hypoxic ischemic encephalopathy encompasses causes not only of hypoxia but also of ischemia, hypoglycemia, and even prolonged seizures. The histopathological features of hypoxic ischemic encephalopathy shows anoxic neurons, neuronophagia, cortical atrophy, and gliosis. Histopathological features of cerebral infarcts range from anoxic neurons to neovascularization and liquefactive necrosis to complete infiltration by macrophages, clearing and formation of cystic spaces, and subsequent formation of a gliotic scar. Embolism remains one of the most frequent causes of ischemic infarction. Most emboli are fragments of blood clots that originate in the heart or major vessels. Some emboli consist of atheromatous material that is detached from the ulcerated atheromas of the aorta or carotid arteries. Besides the usual causes of infarction, mortality from SARS-CoV-2 or COVID-19 has also significantly been associated with ischemic stroke. Microscopic examination of ischemic and hemorrhagic strokes when considering the cerebral cortex are quite similar. So eventually, I'd just like to end this seminar for today on a lighter note with a quote by Edward de Bono, who once said that humor is by far the most significant activity of the human brain. So yes, always keep smiling. Thank you so much for your patient hearing.